This next person is a pain psychologist with expertise in developing and implementing non-pharmacological treatments for chronic pain across healthcare systems. She is an associate professor at the University of South Florida's Morsani College of Medicine and director of behavioral pain medicine for the Department of Veterans Affairs. And she is coming to us from South Florida. I happen to know because I got to talk with her yesterday. She is also the author of the APA book, Chronic Pain and Opioid Management, Strategies for Integrating Pain. And she provides training and workshops and presentations, like she's about to do, in the public and private sectors on the role of behavioral management in improving pain-related functional outcomes. She's also an investigator on multiple funded clinical trials, frequently authors peer-reviewed publications, and is on the editorial board of Pain Medicine. I have to say, she also is a parent to a 4-year-old, which during these times is honestly one of the highest accolades to be a successful parent and professional. Before I bring her up, we have to officially disclose. So we want to put the official presenter disclosure up so that we are in full compliance with all CME regulations, because that's what we're here to do. And would you please all give a huge warm welcome to Dr. Jennifer Murphy. Dr. Murphy, so nice to see you again. Welcome.
Thank you so much. Nice to see you too. Thank you for that, the introduction. And I'm, just very happy to be here today. It's the afternoon for me. So I'm hope that I help get your mornings started off well on the West Coast. Of course, I had hoped to be in Oregon in person. So I'm really, but happy to be here to talk to each of you remotely today. And I think we're ready to go. So I will just wait for the slides. Perfect. So today I'm going to be shifting gears a little bit. As Ian said, I'm a psychologist by training. I've spent the last 17 years focused on pain management. So there isn't a specialty in pain where you're officially a pain psychologist, but I'm a clinical psychologist who spent all of my time focusing on the management of individuals with chronic pain. And I'm going to spend my time today really focusing on how to help minimize, mitigate distress during opioid deprescribing. And really that kind of just goes hand in hand with how to best manage pain in general and the behavioral strategies that we can use to do that. So next slide. You might be able to skip through some of these. We can skip this one. We already covered these guys. So again, I'm gonna talk about some of the psychological considerations when tapering opioids, some of the behavioral challenges that we encounter in these situations, and how we can approach those as providers and also help equip patients with tools that are actually going to help them manage pain and opioids more effectively. Next slide. Okay, so next slide. I don't need to say much about this. I'm sure you're probably all very familiar with pain, its prevalence, its impact. I always am struck by, the fact that it impacts more people than diabetes, heart disease, and cancer combined. The costs at a financial level are tremendous. And frankly, at a human level are tremendous as well, because we really see a great deal of suffering that accompanies chronic pain in particular. Next slide. And they do this about every 5 years, so we should be due for another one if they're on target with this, given COVID. But just to point out, in terms of leading causes of disability worldwide, as someone who works in the pain psychology space, I've got it all covered here, right? So we have low back pain, headache disorders, and depressive disorders, and kind of just today going to talk a little bit about, the interaction between these and how they sort of impact and are impacted by each other. Next slide. So we're all aware of the public health crisis that is opioid medications. I'm not going to spend a lot of time on this. Things have kind of swung, the pendulum has swung in the other direction now. And so now we're really focusing a lot more on how do we really do the right thing for patients, take their needs into consideration and work collaboratively if and when tapering is the right thing, or, identifying opioid use disorder and switching to appropriate medication-assisted therapy. Next slide. And my full-time regular job is actually as the director of behavioral pain medicine in the Department of Veterans Affairs. And, there's been a tremendous focus, of course, not only within, the VA, but absolutely everywhere in our country, a focus on opioid safety. And a lot of that has also been focused on prescribing and guidelines and, changes in behavior, some of which have been very helpful. Others, potentially have not been done in the most thoughtful or judicious fashion. And we've seen some negative impacts from that as well. So right now we're really trying to balance that. Next slide. And this is a nice, I feel, kind of quote just backing up what I just said about that, which is really, that this lies at, the intersection of these two really important and difficult, challenging public health issues, which is basically, reducing the burden of suffering for those who have pain, which as a pain psychologist, your big focus is on reduction of suffering. You want to see reduction of pain intensity as well, but you're really focused on suffering. And also, of course, thinking about how can we mitigate risk, minimize safety issues, and really balance out the harms that can result from the use of opioid medications, with really helping people, maximize their quality of life. Next slide. So one of the things I know Dr. Coelho alluded to this is that, something that we've seen more recently, of course, is that with starting in, I would say 2015, the CDC guidelines came out in 2016. These were guidelines, right? But they were often treated a little bit more like mandates. And so there were things that we have seen that have not been helpful for patients, including, the abrupt tapering, cutting people off, not doing things in a collaborative, thoughtful fashion, and really not supporting patients with other ways to manage their pain. And so this is something that's really, really important as far as what we're going to talk about today in terms of how can you do this in a responsible way. Next slide. So next slide, I'm going to talk a little bit about, so what do we know about opioid tapering? The short answer actually is not enough. Having said that, we know some. And so it's important. I just I'm touching on only a few studies, just to give some information about, what's out there in terms of opioid tapering studies. There are many of these are in progress now. There's been a lot of money put towards this as far as funding. And so we will know more in the years to come as far as, and I'm focusing here on things that may support opioid tapering and the outcomes of those things. So next slide. This one really focuses on outpatient tapering. This was an outpatient community-based clinic in Denver. So not too terribly far from most of you. And so the majority of people in the clinic, 80%, totally voluntary opioid reductions ranging from 25 to 100%. And just some of the things I'll be highlighting is that, what we saw there was no significant change in pain for the majority of patients. Some actually had pain reductions. Many had pain reductions. And one interesting finding here was that the dose at baseline actually didn't predict, how well people did. So even those who were very high dose at baseline were actually equally as likely to reduce or discontinue use and see the same level of benefit or stability as far as their pain. Next slide. This is another one. I know we have Dr. Sullivan involved in this conference, which is amazing. This was a focus on support for patients who are going through an opioid taper. Next slide. And this found that, so this was an RCT, so, a solid design here where they looked at, those who are going through the taper and offered the support and others that were just going through taper via usual care. So again, what they found was that there was not only, of course, the lower opioid dose for both groups who were undergoing taper, also lower pain severity, which is, again, something important to remember in terms of working with patients. And those who received were in the support group actually improved significantly more in terms of a lot of the things that we focus on as a behavioral pain care specialist, things like pain interference, pain self-efficacy, and perceived opioid problems. So more than just having the pain and opioid changes, actually there were improvements in the areas that we really care about, which is about function and pain-related interference in day-to-day life. Next slide. And this is from a study that I headed up some years ago, just kind of giving some comparisons across settings here also, although I know this is a more unusual setting. Next slide. This is actually an inpatient tapering setting. And so it looks like these may not be my most recent slides. So let me go back to the last slide. I can talk about that without the slide. So this was a total of 600 continuous admissions to a 3-week inpatient pain rehabilitation program. And that program, which is the only one in the VA, it tapers everybody who comes in the program on opioids off of them. It's a voluntary program, of course. So in this sample, about 40% of the people were on opioids. And what we found here, we sort of always had this clinical experience that people who were on opioids did just as well as those who were not, and going through this pain rehabilitation program. But we didn't actually know. And so when we took a look at the outcomes, what we found was that those that were tapered off during this intensive pain rehab program actually fared as well or better. They actually did better on several measures in terms of their improvement than those who were not on opioids at admission. So again, this is a very specific treatment that I know is not widely available, but it's, really being able to compare when you provide, this team-based treatment, that those who were tapered off of opioids did just as well or better than those who weren't on them to begin with. We were very pleased to find that. Next slide. Okay, and sorry, okay. So I'm going to skip. We can go ahead and skip that one. Yeah. Yeah, so I can start here. That's good. So what I really want to focus on today is, that the important thing, and it's certainly always what drives us as far as a psychologist who's working either on a team or independently with somebody going through tapering, or just assisting with pain management, is really thinking about whole person care all the time. Focusing on that we cannot separate out these pieces of an individual, that when it comes to chronic pain, especially, and of course, especially with high impact chronic pain, that there are many, many different things that impact and are impacted by pain. So, there's there are of course the physical issues, the medical issues, as well as, trauma, learning history, behaviors, feelings, thoughts, of course, expectations about treatment, as well as many of the social environmental factors in terms of the support we have or don't have. And all of those things together is really the person who presents to us comes with all of these things in the room. And so the importance of really being aware of that all the time when we're interacting with somebody. Next slide. So, we really have to think of, to successfully taper somebody, we don't want to think about pills or biomedical options as the only avenue for pain management. Undoubtedly, that is one piece of the puzzle. But in our culture, we've definitely sort of think about things from more of an acute pain model, that sort of find it, fix it model that doesn't work very well for pain. So we really have to think more about, who is this in front of us and what are the psychosocial factors that are impacting their pain experience. And really talking about things in that biopsychosocial whole person frame from the beginning is a key to a patient, really buying into, because oftentimes they don't from the beginning, a lot of the behavioral strategies that are really critical in managing a taper and in managing chronic pain more generally. Next slide. And this is really what we see a lot of the time. I'm sure there are some, simple cases, things that are more straightforward. But a lot of what, sorry about that, I'm used to seeing more in clinical care are these highly complex presentations where we have medical and psychiatric comorbidities, social circumstances as far as, employment, housing, often have substance use issues, and then of course pain. And so a lot of times, our patients are very much in this area where there's a lot of overlap and things are highly complex. And so again, to try to treat something that's so complex from one perspective, or sort of by a single focus, and think that that's going to work, is really unrealistic and short-sighted when it comes to really wanting to optimize outcomes. Next slide. And next slide. So one thing we know about tapering, and this is part of what was brought up before, but things just haven't been handled in the most clinically sensitive or therapeutic way. And so oftentimes we find that patients are defensive kind of from the very beginning. When we encounter them in clinical care, they may not be very open to hearing what we have to say, because they have a lot of their own experiences where they either feel shamed, and that happens at the hands of people in the healthcare system, which is unfortunate. Feel like they've been, called a drug seeking or a drug addict, things like that, that are offensive to them. Sometimes there just hasn't been sufficient explanation provided for why tapering is a reasonable option to consider. Sometimes it's just been more of a forced situation, which of course, I don't think any of us would be very pleased with that. And with providers, there's also a lot of challenges. And sometimes it's just, the logistics of what does a taper look like. But I think a lot of that's been figured out at this point, or at least a general idea of what makes the most sense. Often what's more difficult is actually how to manage the behavioral challenges, personalities, things that, the way that somebody may interact in a visit. And so what do you do with that? And how can someone in the behavioral health realm sort of help with those challenges? Next slide. So those experiences really lead to kind of a parallel process where everybody's frustrated, right? Providers are frustrated. Patients, of course, have a lot of their own frustrations. Next slide. And a lot of times, this is a divisive area where, and even, I had to do a training recently, and actually, I was a little bit upset because it was I felt sort of, it was quite divisive, right? It was sort of this, pain patients are this way and they're difficult and they're this and they're that. And really kind of like perpetuating that us versus them mentality. And one thing that I really try to make kind of an important point when I speak at this point is instead of looking at it in that way, but instead really thinking about it as there's a lot of common ground, there's a lot of shared experiences. Patients are frustrated, and so are providers, by often having a lack of a clear cause or a diagnosis, wanting something more satisfying in that regard. Having a lot of treatments that have been tried and not really seeing much success or improvement, frustration around that. Really this question of, am I believed by this person, and do I believe this person, and sort of all the emotions that go along with that. And also really just, obviously, physicians want to help. They're in a helping profession, and feeling sort of helpless, like I don't know what to do. And patients, of course, feeling like all I want is help, and often sort of a flavor of desperation there because they feel like they have done a lot, or they feel like they do just need more medication for things to get better, or to find that sort of magic thing that's going to work for them. And so anyway, I mean, kind of reorienting to think we are experiencing a lot of the same things instead of, we're on opposite sides of the ring here. And this is something that creates further division. Next slide. So it's really important to remember, I think, that the way that, providers approach and respond to clinical interactions, that in the office, there's two people, right? And so how do these clinical interactions affect outcomes? And we really want to try to help move towards, increasing patients' self-management, self-efficacy strategies and skills, so that the communication is improved, and so that people feel better equipped, with how they can manage pain and any changes in opioid medications. And I think I'm going to talk a little bit more about sort of language choices, but I think it's just to, mention it, that it's not just, kind of, again, the what we say, but what words do we actually choose? And oftentimes, if we're not sensitive to the language that we use, I just think of it like people's ears just kind of close up immediately, and they don't even hear what you're saying because they've already sort of shut things down. And so oftentimes, if we can really be thoughtful about language and think about that on the front end, then we can make a lot more progress and headway as far as clinical interactions. Next slide. So one of the most important things, I think, just to setting up like a successful, tapering relationship, is to collaborate, validate, reassure. So really what we're talking about is communicating in a way, again, that's sensitive, that fosters that trust, and that, the patient really feels like something isn't happening to them, that this is something that's happening together, right? And so you're being really explicit about, how important it is to share concerns and what is going on with you, and providing feedback sort of in real time, calling the office. And there's of course a lot of fears that I'll touch on, but, designing a plan, that's a slow, thoughtful plan where we can address any symptoms that come up, as we're moving through things, with the hope being that if we're doing things in a slow, reasonable way, that we're actually not going to see a lot of withdrawal symptoms or issues, that we're going to be able to move through it in a way that makes sense, and is not harmful to the patient. I think there's also a lot of this fear about just feeling, abandoned by providers. And so, we have some qualitative feedback around a lot of the themes I'm talking about here. And so really underscoring that this is a unique situation. There's, that seems to go a long way with patients. Everyone feels like they are different, right? They're different. Their situation is different. And validating that and going from there, goes a long way, to making progress.
Dr. Murphy, I'm here to lean into the collaboration that you're talking about.
Yes.
And I know you're using a previous version of your slide deck that is not the most up to date, and we've been working to get the right one for you, and we apologize, and we have it now. So if it's okay, we're just going to put in the new version of your slide deck right where you currently are, unless you tell me you don't want us to do that.
That sounds perfect. Thank you.
Okay. Thank
Appreciate
you, Dr. Murphy. And to everyone, please continue dropping in questions and comments. I'm taking notes, and Dr. Murphy, I'm right here. If there's anything we can do for you, don't hesitate to shout it out. So we're going to go back to, I think, the right next slide. That is the actual right next slide.
Okay. Perfect. Thanks.
Yeah, no problem. Thank you. Oh, here. Yeah, I think it's coming somewhere over here. And while that's popping up, I want to say again, I feel so interesting as somebody who is not an expert in this field, but I heard Dr. Ferris talking earlier about sort of humility, and it sounds like you're hitting a similar theme, in terms of when you're working with those patients who are, who maybe are a little defensive. So anyway, really interesting. Okay. I think this is where we want to be. This is the new deck, and I'm going to step off stage again. Thanks.
All right. Sounds good. I'll take it from here. Thank you. Okay. So let's talk a little bit about, some of the specific challenges that come up during tapering. Next slide. Yeah, so this was touched on in the last presentation. Again, Dr. Sullivan's kind of he may expand on this, but one of the challenges, of course, that we see is this phenomenon of adverse selection, right? That the highest risk patients are on the highest risk regimens, and so those that may be, are appropriate for opioid tapering, and could benefit from it, may be the least interested in it. And so there's a lot of reasons for that, of course, but there may be not a lot of examination around, or even honesty. I think that's certainly a real human experience about, how opioids may be impacting things in a negative way in their life, or aren't beneficial to functioning. And I think that's what Dr. Polo was getting at too. It's like we can be doing something that's familiar, but it does not mean that things are really going well in our lives or that our functioning is good. And so certainly that's something that we focus a lot on is What does that mean? What does that look like? Kind of translating things to function. Next slide. And the biggest thing really as far as challenges is, of course, just, fears, right? There's often many fears around tapering changes to opioids. And a lot of times I think of this as kind of again, even if things aren't going that well and life isn't that great, sort of maybe the hell you know is better than the one you don't, right? So, well, it's not great, but at least I know what it is. And if we make any changes, I have all of these various things that I'm concerned about. So, I mean, one thing is really asking people very directly, having more open communication on the front end about, what are you most worried about? And these are kind of the top answers, with increased pain absolutely being far and away the most common thing that people are worried about. But also things like withdrawal symptoms, or that other things that they're going to try or be offered are not going to work well. And again, regardless of how well things are working now, still just a concern about that. Next slide. So let's talk about a little bit, each of these a little bit. The increased pain fear. And again, this is a lot of what, as a psychologist, a behavioral health clinician, a lot of time, is spent when people are contemplating the process, contemplating tapering, sort of on the, before things even get underway, or when they are underway, addressing some of these fears. And so one thing I rely on to some extent is really what we know from the data that we do have. And what we know and this is just across the board, is that we see not only improvements in, functioning, of course, and often quality of life, things like that, but we actually see that pain either stays the same or improves. We see that in these systematic reviews, in the trials that we do have, and that their quality of life is better, and that pain is the same or better than it was. And this is thousands and thousands and thousands of individuals. And even though the person in front of you is not one of those people and feels that their experience is unique, it can be helpful to at least share that, so that they're aware that this is a very common thing to be concerned about, that you completely understand that. But what we know from all of the people who have gone before is that actually, is not the outcome when we go through an opioid reduction. Next slide. The other thing is just to, potentially just talk through things a little bit, and really, just start very small. So oftentimes just thinking about things as sort of an experiment, if somebody's open enough and willing to try, let's just try it and see how it goes. We're going to be in communication. We're going to adjust as needed. We're going to do really minimal changes, especially in the beginning, or really the whole way through, and evaluate as we go. And also having that conversation about, what the opioids may or may not be doing for them at this point is really important. Next slide. So, and some of this may seem obvious, but the other thing with the withdrawal symptoms is, I think a lot of people, when you even start to consider reducing opioid dose, they are very concerned about withdrawal symptoms. And, often it's important to just make sure that they know that this is not the same as, running out of medication and being cut off, or not having any medication at all. And that, this is going to be done in a way where it's slow. And if we do it in this measured sort of way, and we have communication about what's happening, then we can, avoid these things for the most part. And that, of course, there may be a little more restlessness or some of these symptoms that do happen at times, but really talking through those. And again, having expectations that does not mean anything terrible is happening, that it makes sense that we're making this change. And that, this is something that's really, these minor things could be expected, but we're going to take things very slow, and it's not going to be a withdrawal situation. Next slide. As far as other treatments, I'll get into the, of course, the behavioral health stuff, but of course, this is a huge issue, right? That people don't really have the information that, evidence-based first-line treatments like cognitive behavioral therapy have solid support from decades and decades of research, that not only do they improve functioning and, pain-related interference and in all aspects of life, but they also actually help with reduction of pain intensity. And so, things like CBT or physical therapy, obviously being key, movement is medicine, interdisciplinary pain, these all have strong empirical support. And one of the pluses, there's so many pluses of, I was going to, talk about the last couple of years, but what, the boom in telehealth options has actually been, kind of a trial by fire, but really increasing access to some of these things that have been harder to get. So some of the behavioral health options, even PT, for people who are in more rural areas. Next slide. Also, I was just going to mention too, in addition to sort of non-pharmacological things, we can also look at, the data that we have around things like, non-opioid medications. This SPACE trial is really important to be aware of, and in case you aren't, that, looking at an opioid and a non-opioid group over 12 months. So this was a nice trial. Did not differ in pain-related function, and the pain intensity actually was better in the non-opioid group. And so really just the support for, is this something that, we can think about moving forward? Next slide. And this is just a quick mention for obviously the importance of evaluating and treating opioid use disorder appropriately. We do not want to, engage in a tapering plan. If someone has opioid use disorder, we want to transition them to medication for opioid use disorder, and make sure that we're concurrently providing the support that we need for pain management. But just wanted to make sure to say that I'm in no way saying, everybody should be tapered in the same way. Those with opioid use disorder absolutely need to be treated differently. Next slide. So one thing that's important, I think, with the tapering plan is really like, what is success? Your success as a provider, your definition of success as a provider and a patient's definition of success may not be exactly the same thing, right? So, is it a reduction of opioids? Is it just, not taking my PRN meds? So really having a conversation around that as well. And maybe there's a kind of a long-term goal or something that would look like success in the long term, but in the short term, what is it? And maybe start there, with the first step. Next slide. And also just thinking through, that a pain and taper care plan, it has to involve a lot of different things ideally. So not just, again, kind of a unimodal approach where we're not thinking about the whole person, but we're actually thinking about all of the different things that go into potentially, making changes and helping to increase confidence. Next slide. And next slide. That one. Okay, so let's get into this part. It's important. Next slide. I just want to make sure we have enough time. So I just want to go over, some of the behavioral medicine basics that are really things that can help with both, pain management more generally, and also pain and opioid management when tapering is occurring. I think one thing I was thinking when I was listening to the last speaker is whether we're tapering or whether we're transitioning to something like Suboxone or whatever we're doing in that regard. I think one thing that is missed a lot is we're either changing something or we're taking something away potentially, and we're not actually offering other strategies and skills. And so this is really a lot about, you want to provide something to empower the person that you're working with so that they actually are, obviously included in the treatment, part of it, understand their critical role, and feel equipped with skills and strategies so that they don't feel overwhelmed and alone, and that they actually have sort of tools in their toolbox to handle things that come up. So that's really what these basics are about, and there are things honestly that can be applied in general by any healthcare professional. I mean, seeing someone who's a pain psychologist and really is going to dig into these areas, that's ideal. But I think all of us kind of speaking the same language, whether that's, a nurse or a physician or a physical therapist, is also a really important piece of how we help people to do better and have more success when it comes to pain and opioid management. Next slide. So some of the important things that we focus on really is one, really, I'm sure many of you have heard of like motivational interviewing. So that's kind of a label that we use a lot now. But, really thinking about what is motivating somebody to engage in treatment, or if they don't feel, if they don't seem particularly motivated for treatment, what is it in their life? What matters to them? What is it that they would like to see change or be different because of their own values? And then, kind of trying to make the connection between those things that are important to them and how making some changes in terms of opioids may actually help getting where they want to go. Next slide. So again, really taking these values that people have, just flipping the script on, instead of what's the matter with you to what matters to you, and then using those things to try to, help move somebody to action so that they're actually, more engaged and more willing to make changes, whether that's related to tapering or to, bringing other skills on board that can actually help them. And so a lot of times, you can really link these things together so that, doing things, being less sedated, for example, on opioids, I could actually participate in X, Y, or Z with my family, where now I usually just, stay home because I don't really feel comfortable doing that. And I really would rather just stay home in my recliner. Next slide. So I personally, my background is more in cognitive behavioral therapy. And so a lot of the time, what we do with this stuff is we really try to link it to concrete, specific, actionable goals. And so one of the most important things I think with goals around tapering is to start small, right? So really thinking about let's consider a manageable first step, because you want people to be successful, right? So that they build confidence and they're willing to go forward. So if somebody is, they actually want to decrease their meds by 50%, but there's kind of a lot of fear around that, and there's not a lot of skills that they currently have, maybe taking a slightly different approach and starting with something else that they can, be successful with, and then building on that is really important. Next slide. The other piece that's really critical to what we do in terms of behavioral strategies is, activation. So trying to address more directly some of the fear avoidance beliefs, you know, emphasizing the fact that behavior actually rewires biology, and that by doing, we can actually begin to impact our thoughts, our beliefs, our expectations, and engaging in and exposure to, things that we're afraid may increase pain or cause injury, to really focus on pacing, the place of activity rest cycles, and really getting that integrated into day-to-day life. So, you can talk about it, let's talk about getting you back to doing things that you like to do. And let's, again, think of one really discrete, identifiable thing. And let's talk about the details of how we're going to map out getting back to that, and again, starting small. Next slide. So pacing is really a critical piece that gets, should be really applied to everything, from actual, activity, going to the store, to even leisure activities. And this is really key to avoiding pain flare-ups, minimizing pain flare-ups, which is often where kind of that increased desire for opioids comes in. So pacing, as far as a strategy for avoiding or minimizing pain flare-ups, is really something that's important in terms of getting through a successful taper and sort of sticking with a plan. And pacing is just, it's not complicated, but it definitely takes a little bit of sort of coaching along as far as the details of doing it. But it's something that people can benefit from and definitely can help with opioid use as well. Next slide. Relaxation, sometimes I just call this we want to learn how to self-regulate our physiology. It helps us to sort of medicalize things a little bit, but this is really about, calming your nervous system, which is really the cornerstone of, helping with pain management, retraining our brains, retraining our nervous systems. And there's a lot of different things that we have at our fingertips these days to help us with that. Next slide. And these are just some of the examples. Next slide. I want to make sure I'm following up for time. So relaxation has a lot of applications for deprescribing, one of which is really important is drug deferral. So a lot of times I talk to people about, if you think you want to take another, pill, stop, and basically just insert a relaxation technique. And then if you still want to take it, and so using that as a way to sort of interfere with that is usually very effective. Sleep disruption, of course, is another huge one in this patient population. Next slide. The other thing that we really focus on a lot is just these unhelpful thought patterns, and really, appraisal of situations and what we do with that information. We know that catastrophizing is something that is the most sort of associated with pain-related disability and pain-related impairment. So, if we can make changes around the way our pain mindset, then we'll have much more success in terms of our treatment outcomes as well. And so that's something that we really focus on. Next slide. Next slide. Sorry, I'm just going to skip a couple here. So here's just some examples of concretely, instead of sort of, I can't take the pain, I'm taking another pill, again, I'm going to try relaxation for 10 minutes before I take it. I can't manage this pain without meds. So a lot of these are sort of those all or nothing types of thoughts, or, often people say things like this. And so how can we kind of balance that a little bit better so that it's not only more accurate, but also more balanced versus the extremes, which typically are not accurate. Next slide. And next slide. So we do often see setbacks, of course, and really in those times, we want to kind of always go back to, what are the skills that they've used that have worked? What are the things that are getting in the way as far as triggers, obstacles, and what strategies are working? What can we do more of? Is there something that we haven't introduced that we can actually start using now? Next slide. So in terms of, what to say, I think this is important, is how we sort of communicate this information. And I'm going to talk about that actually in our panel discussion. So I'm going to go to the next slide here. I said this before, I just want to make sure to reinforce this idea that, being aware of the language that we use, a person with pain instead of a pain patient, it doesn't sound like much, but it's kind of like, a person with schizophrenia versus a schizophrenic, it's somebody and this is something about them versus their entire identity, and sort of reinforcing this idea that it is their entire identity. And really acknowledging pain as a loss, I think is powerful for people, especially people who are defensive. Really acknowledging that there's, was their plan for life and their actual life, and that this is really like a grieving process, and that you understand that and you acknowledge that, can be really important to a lot of patients and kind of, again, take them away from that defensive place. Next slide. So, and I know we need to wrap up, so I'm going to finish up here just by, kind of mentioning again some of these key messaging sort of tips for people, really validating, making sure that you are acknowledging that they're not crazy. This is not all in their head, that there's a lot of things like behaviors and beliefs that affect our physiology directly. And so we actually need to attend to all of the pieces of you as a complex individual in order to actually get the best outcome that we can. And we want to really think about these different ways and strategies that we have to turn down the volume on pain, instead of doing things that are actually going to amplify pain. And we have the power to do that. And that's actually a really empowering thing for people. So I'll stop there.
Well, and Dr. Murphy, thank you. And I just want to reiterate what you said already, which is we're not really stopping. And you have so graciously agreed to be part of the panel discussion that is right after we take a break for lunch in about 8 minutes. So there's lots of opportunity. But would, before we lose some of the great stuff you've just been telling us about, to give people just a second to ask questions. If there are, questions about this part, and also knowing that we are going to have that panel discussion, and all of the panelists, including Dr. Murphy, really expressed that they would love for that discussion to be as interactive as possible. So I'll just remind everyone that it's okay if you are in the chat and asking questions and dropping in comments. So I'll tell you one question that I had, Dr. Murphy, as you were talking. And again, I know I've said this before, but I do feel sort of privileged to get to be here as a lay person, and because this is such important stuff that's obviously in the news all the time. I mean, it's really interesting. But hearing you and Dr. Coelho talk, I feel like there's really this. It is a kind of a collaborative approach for each patient, that there might be a team, and it sounds like I've heard you maybe between the lines both saying that, maybe sometimes there are other approaches than the ones that you are advocating that have been employed. So I'm wondering, like, how do you get that team kind of onto a similar page? How do you move in these directions that we're talking about with appropriate paying and recognizing the person of patients and some of those things that, may not have happened previously? Is there any tricks or tips for that?
I don't think there's tricks. I think that's actually one of the most challenging parts, is you tend to have on kind of a typical, say, primary care team where you have people from different disciplines who have had different training, with different emphases. So, it can be that people really are coming from their own, we're all coming from our own perspective, but I mean, where there hasn't been sort of an explicit model of treatment. And so one real advantage to working in more of an interdisciplinary program where you actually have a coordinated plan of care is that you have sort of this shared philosophy, shared treatment goals, shared vision. And I do know, I mean, in terms of some of the best practices that I've seen as far as a primary care setting where the team is a bit more disjointed at times, visits may be less frequent. Having times where those different disciplines come together, do education together, but mainly discuss cases together, like actually taking one thing that, doing things like, we've seen it more in like the cancer world where you do cancer boards, but like a pain board where you take an hour where everybody comes together in the same room or on the same Teams link, whatever, and talks about a couple of the people, like a case that went well and a case that went terribly, or two cases that went terribly, whichever, and really talks through that together to try to actually become, learn from each other, but also get more on the same page in terms of how you want to practice, and what you want your team to sort of look like. What is your philosophy? What do you want to be telling people and not telling people sometimes is very important too, so that you are all sort of speaking the same language. But it is, I'll tell you, it's a challenge because there's turnover and there's, sometimes strong personalities and differing opinions. And I think, using the successes to really be like a template for what works best can be really useful.
Well, that actually kind of, it's interesting because my other question that I had as I was listening to you, you used that phrase that it's, people are confronted with the real difficulty of the hell that they know versus the hell that they don't know. And as I heard you speaking, it sounds like there's a lot of counterintuitive realities about that future for that person. And so I wondered, like, what are the things that you highlight for people to say, hey, there's a place in the future that is different than what you might be anticipating? Is that a key? Or because, what do you say and what do you not say? Right. I mean, I don't, if that is that, yeah.
Yeah. I think that, I mean, oftentimes when you do a more of an in-depth clinical interview with somebody, they might walk it back when you start to talk about making changes to opioids, but oftentimes the picture that they paint of what their life is like right now and a lot of the things that they've lost is pretty bleak. And so, I mean, you want to focus on wellness and building on the positive and the good. So it's not about, being kind of a doomsday person, but I think listening and then kind of reflecting back to the person that it sounds like things haven't been great for a while, would you be open to considering making some small changes to see if that made an impact? So really, a lot of times it's almost just, bringing back to them the picture that they have kind of built for you, and asking them to sort of take a little bit of a leap with you and take that first step and see how it goes. And again, as far as the team goes, and knowing and having everybody there to support that along the way, that we're going to be here to help you through this, and you could see this person or do this, or, again, we're not abandoning you. Let's build out a treatment plan. And then let's start, and then let's see how it goes. it's kind of, it's a similar approach for a lot of things that we do in life. You know, it's like the first step, right? Just sort of the getting going part. And using most of the time their own reality that things are not going well and that there's a lot that could be improved in their life. And using that motivation that they have, even if it's one little thing, like trying to build on that to get there.
That all makes sense to me. I know I love being on a run, and I have such a hard time getting on a run. If somebody would just help me start, then I'm like having a great time. I just need to do it more often. So, Dr. Murphy, as promised, we have to stay on schedule, and at least here on the West Coast, it's time for lunch. I'm guessing it is, it's well past for you. And given that you're going to be back with us, I feel it's easier to say thank you and more to come. We're not really ending.